I noticed in that report at the end, you identify all the members of the task force. And there's representatives and senators from the state of Minnesota and many organizations, Minnesota Nurses Associations and so forth. But I didn't see the Minnesota Medical Association or any medical association representing actively practicing physicians. Is there a reason why they weren't on that task force?
There were actually 2 physicians on the task force, myself and Dr. Zink.
3. I said practicing physicians. Well, full-time practicing.
Yeah, well. So a couple of us still actually practice.
Okay.
So,
but as an organization,
we had, I think, pretty good comment from organizations as we were going along.
Okay.
If you want to go to the website, there's a lot of information that came from physician groups. We actually actively sought input of physician groups in the work group. There were a couple of meetings, one in particular that we did at Metropolitan State University, where we actually had the representatives of the different organizations that were attending the meetings engage in a discussion about some of the things we ought to achieve. So it was actually one of the more fun meetings because it wasn't really a very scripted meeting, but it actually allowed us to sort of get people to say, well, this is maybe what we should think about. It was a good back and forth. So I you know, representative democracy, it's hard to say you'll have certain representatives from each group. I think we had pretty good input from almost everybody.
Okay, thank you.
Just to clarify, when they put the group together, they intentionally did not want representatives from different groups.
I see.
They did have input on Dr. Woods and Dr. Zink's.
Okay.
They did not ask for input.
Thank you. Moving on to our last speaker, Ann is going to talk about a very interesting topic that has been in front of the physician community for a long time. I was out of Minnesota for 3 years working with clients in Washington, D.C., Houston, and Los Angeles. When I came back, I had a meeting at the Minnesota Medical Association, and they had just had a vote. This was in '94. And they just had voted on the single payer system. And the association was split right down the middle. So it'll be interesting to see where it is today. So Ann?
So thank you very much for inviting me to be part of the panel. I know I'm last, so I'll try and keep my comments brief too so we can get to the more Q&A. But I am here representing the Minnesota chapter of Physicians for a National Health Program. So PNHP is a national organization, but our Minnesota chapter was founded in 2007, and we now have nearly 1,000 Minnesota physician and medical student members in our chapter. And the group is really connected by the conviction that all patients deserve access to high-quality health care regardless of age, health status, or income. And so we believe that the most just and efficient way to do this is via a single payer. And so for those of you not familiar with, how many of you are familiar with the term single payer? Okay, so good. I'll just define it the way I explain it for those who might not be. Basically, single payer is referring to a system where all health care is paid for via a single pool of public dollars, but paid directly to providers who would remain private, just as our system is now. So the delivery system in a single payer is private, but the funding is public. And so some people like to use as a synonym Medicare for all, which is a pretty apt analogy because Medicare uses public dollars to pay private providers for care. The problem with the analogy is that you would have to say expanded and improved Medicare because Medicare, as we know, has some gaps in terms of beneficiary coverage, and it's a pretty poor payer for physicians. And so we say expanded and improved Medicare is a synonym for a single payer. So the main reason, in my mind, the main reason this option is appealing is because it's really the only proposal out there that gets us to truly universal coverage. So as Manny pointed out, Minnesota does rank pretty well nationally in terms of our uninsurance rate, but we're still at about 9%. But the problem is, even after we enact all of the reform that's coming, we'll still have about 260,000 Minnesotans that are completely uncovered. And so, most, or really all of the other wealthy nations in the world demand a 0% uninsurance rate from their healthcare system. And so we feel like we're falling quite short still, even with the ACA. But the other reason that single payer is appealing is in the cost savings that it brings. And so that's really what we've come here tonight to talk about. And so an important number to remember is that when you look at healthcare spending in the United States, we spend 31 cents of every dollar administering our system. And this is about double the administrative costs of all the other wealthy nations who are covering everyone. And so when you hear that 31 cents number, it really comes on two sides. So one side is us. It's the primary care doctors, the clinics and the hospitals who have to really employ sizable billing departments and administrative staff in order to extract payment from multiple payers. So as you know, all insurance companies come with different benefit sets, different prior authorization requirements, different drug formularies. We're all familiar with this in our daily life, and this requires a lot of administrative complexity and cost in our practices. But the other side of that 31 cents is borne on the side of the payers or the insurance companies themselves in their overhead costs. And those overhead costs are quite high. They're variable from company to company, but a lot of that overhead money is spent doing things that really have nothing to do with healthcare. So things like advertising and marketing your products, things like paying your CEOs sometimes excessive salaries, things like underwriting policies, negotiating contracts with multiple providers, and in some cases, paying dividends to your shareholders, although, like we've heard, most Minnesota insurance companies are not-for-profit. And so the thought with single payer is that you could recoup a lot of that wasted administrative money by taking those healthcare dollars and spending them on health rather than administrative spending. And so the Lewin Group is a large health policy and economic consultant group that released a fiscal analysis last year in March of single payer in Minnesota, and was able to estimate for us that we could reduce our healthcare spending in the state by about 9% if we transitioned to single payer. And so this would come to about $4 billion. And of course, we would cover everyone while we did it. And so, kind of bringing this down to our practice as primary care doctors, I think the problems with being uninsured are pretty obvious to all of us in terms of people just not being able to access care. But there's actually good data that links uninsurance status in the U.S. to death. So when you control for all other demographic variables that might play into your risk of death, uninsurance alone is a cause of preventable death in the U.S. And this is a uniquely American phenomenon, of course, among wealthy countries. But what concerns me more about the reform that's coming is the issue of underinsurance, which I think is really critical, and it's not going to be solved. So Manny referred to the minimum actuarial value of 60% in the essential health benefit that's coming. And if you have, a $1 million illness, that's easily, for some people, not enough coverage for you. And so we see patients, or I see patients in my practice who, because their deductible is too high or their copay is too high, they simply don't access care. But I think in terms of underinsurance, probably a more compelling way to think about underinsurance in the US is to look at bankruptcy data. And so it's really impressive. So the majority of bankruptcies in America are actually related, at least in part, to medical bills. So again, uniquely American phenomenon in wealthy countries. But of those who go medically bankrupt, so people who go bankrupt due to medical bills, 77% of those folks had insurance when they became sick. And so what this means is these are folks who played by the rules, they had their health insurance, they got sick, and they lost all of their assets anyway. And so this is a good example of a major system misdesign in my mind. And I think that one of the problems with the reform that we've done is we're not changing anything about underinsurance. So I think, we've talked tonight about paying for value and reforming care delivery and integrating care, which are certainly issues that deserve a lot of merit and attention. I still feel that if a patient doesn't have access to the system, all the care coordination in the world isn't going to help them. And so I think we really need to get a way to get everybody in the system, and then we could much more effectively reform how we deliver care. And then I'll just close. This was an interesting, I brought a copy of it if anyone's interested. Health Affairs just last month in December published a survey of primary care physicians, so very pertinent for this audience. And they surveyed primary care physicians in 10 wealthy countries. So these were Canada, the US, the UK, Norway, Denmark, France, Germany, Switzerland, Australia, New Zealand. And they asked them really a broad group of questions. Some was related to use of electronic medical records, some was related to interactions with specialists, other questions were related to patient access, and other questions just related to job satisfaction and how you like practicing medicine. And the results were somewhat probably predictable, but I still think interesting and worth a review. So when asked if patients experienced financial barriers to care, the US primary care doctors, 59% answered affirmatively, so nearly 60% of us. And this was by far the highest of any of the nations that were surveyed. And likewise, we were in the extreme, but at the opposite end. When asked if our system works well, only 15 or 15% of US physicians answered yes. And then finally, they asked physicians the question, they asked them to report if the time they or their staff spent getting patients needed care because of coverage restrictions is a major problem. And again, the majority, 52% of US physicians answered yes, and that was by far higher than any of the other countries. And so I think this reflects the work that we do dealing with the multiple payers. And that time can also be translated into money. There was a similar study last year where Health Affairs reported or went and looked at the time that is actually spent, or I'm sorry, the money that is actually spent in primary care practices interacting with payers. And they found that in the United States, the average US physician practice spends $82,000 per doctor per year interacting with payers. An equivalent practice in Canada is spending about $22,000, so a little more than a fourth of that interacting with their payer per physician per year. So just bringing us back to that issue of administrative spending and where a lot of that is coming from. So I'll quit there, but just in summary, single payer, the reason I'm promoting it is because it actually gets us to zero on insurance and saves money at the same time.
Thank you, Ann.
Mm-hmm.